Welcome back to the Hill Update. I'm your host, Dean Allison, Member of Parliament for the riding of Niagara West. I've been off the last couple of weeks as a result of the federal election campaign, so it is great to be back. I want to also thank David Sweet for sitting in for me and hosting the show while I was out campaigning. The guest joining me on the show this week was here on this show exactly 10 months ago to the day. His name is David Redman, but before I reintroduce you to David, what would you imagine that we were talking about 10 months ago? If you guessed lockdowns, you would be correct. And at that time, we were only in our second lockdown and talking about a possible third lockdown. And at that time, not all the provinces had actually been locked down. Since then, every province in this country has been locked down, and we actually hit that third lockdown. And presently, governments around this country are talking about the possibility of a fourth lockdown on the horizon. It almost seems like Groundhog's Day. 10 months later, absolutely incredible that we are still having this conversation. And that's with the vaccination rate as of October the 4th from the Government of Canada's website of single doses of 87% and double doses of 81% of all those over 12 and over. David, welcome back to the show. Before we get started though, I need to tell the listeners a little bit about you. So who is David Redman and why is he qualified to talk about pandemics? 27 years in the Canadian Armed Forces and a retired lieutenant colonel. You were responsible for coming up with a plan of executing with the withdrawal of 18,000 troops from a base in Germany, which included equipment, families, basically a small city. And after the forces, you went to work for the province of Alberta in emergency management. You were working for the government of Alberta, and then 9/11 happened, and you were the director of community programs. The next day, you found yourself in a room full of experts representing key government and private sector interests, wondering, how do we deal with this new threat? So what did you do? Paul Cellucci, who was then the U.S. ambassador to Canada, was so impressed that he had you come to Washington to brief the Senate and the House committees on what you had done. You retired as the executive director of Alberta Emergency Management Agency in 2005, advised the Federal Auditor General's offices of best practices for emergency planning. And you just co-authored a paper with Dr. R.A. Jaffe titled The SARS-CoV-2 Pandemic in High-Income Countries Such as Canada, A Better Way Forward Without Lockdowns. And this paper was just published on October the 1st. What's the response been as you've moved forward over the last 10 months and what you guys talked about in this paper that was just released on October the 1st?
Well, I think you hit the nail on the head. It's Groundhog Day. And maybe it's best if I start off with, in any emergency, the very first thing you do is you define a mission. And we got the mission in this pandemic in every province and territory in Canada wrong. The mission should have been to minimize the impact of COVID-19 on the province. Instead, the mission became very quickly to minimize the impact of COVID-19 on the medical system. That change in mission, that misdefined mission, has driven everything. But the second thing that happened immediately, which is exactly the opposite of what should happen in any emergency, is the medical officers of health and the premiers turned to the age-old tool of dictators called fear. And they have now built a wall of fear across our country that it will take at least a year of constant re-education, telling people the truth about COVID in order to come that wall of fear. And until that wall of fear is overcome, we're going to play Groundhog Day.
Well, one of the things you mentioned, fear. Fear is incredible, and it's not to be. You've talked about it. I mean, I remember I was talking about it 10 months ago. Fear was an issue that you said we need to deal with right away because we're looking at case counts and all these other kinds of things. But fear, not only is it tough on us, but it divides families. It divides friends, it divides communities, organizations, and really, if we look at what the election we just came through, it's actually, I think our country's more divided than it's ever been.
Yeah, I have to agree with you. And the use of fear in an emergency is unconscionable, and yet it is the daily tool. I live in Alberta, and you can just imagine what's being said on the TV every night here as we're now peaked and gone over the top of our fourth wave of Delta. And it's a never-ending barrage on the TV and in the print media every single day about each evolving step. They keep coming up with a new way to continue the methodology of fear when it is A, completely the wrong thing to do, and B, causes the wrong things to happen. I think the most important thing for people to realize is COVID is seasonal influenza for everyone under the age of 50. And yet you would never know that from listening to the doctors who own the waves every night.
The severe acute respiratory syndrome coronavirus 2, or the SARS-CoV-2, that caused coronavirus disease in 2019, or as we've been talking about it, COVID-19, has tragically led to many deaths worldwide since the pandemic was declared in March of 2020. Attempting to flatten the curve of cases and deaths, governments have implemented unprecedented restrictions on charter rights and freedoms. The lockdowns and the circuit breakers, which were time-limited lockdowns that were never time limited. The mistaken assumption is no one is protected until everyone is protected. Another false assumption was that lockdowns are highly effective to reduce transmissions. Let's go back. That first mistaken assumption is that no one is protected until everyone is protected. David, what are your thoughts?
So let's begin there. Absolutely. The one thing we did right from the beginning that caused the majority of deaths in our country is we refused to recognize that COVID-19 is very age selective. Average age of deaths in Canada is 84, and the average number of comorbidities is 2.8. So these were very frail seniors, but we knew that in February 2020. And in the paper, we very clearly prove the age discrepancy of COVID. So if you're under 50, it is in fact less deadly, less risk than seasonal influenza. And as you work your way up, the breaking point is age 70, and people over age 70 are very, very more susceptible. But it's important to note that even over the age of 80, 77% of all people who catch COVID-19 survive. People under, and especially children are 4 to 5 times less susceptible to COVID, anyone under the age of 20, than people over the age of 50. So when we say we need to protect everyone, we didn't. And by enforcing lockdowns on the healthy population under the age of 60, we have totally damaged them. And we'll talk more about that later in one of the false assumptions. But the entire idea that everyone was at equal risk from COVID is simply false.
Another mistaken assumption that you talk about in your paper is that lockdowns are highly effective to reduce the transmission. Explain what you mean by that.
All right. So even before the first wave, we knew from the non-pharmaceutical interventions document that had been published by the best infectious disease doctors in the world that the use of non-pharmaceutical interventions, which we now call lockdowns, things like closing business, closing schools, have minimal effect, if any effect, on the transmission of viruses. However, they have severe consequences that we'll talk about in a minute. So following the first wave, the best infectious disease doctors in the world studied lockdown versus non-lockdown countries. After the second wave, they did it again. After the third wave, they did it again. There are at least 29 peer-reviewed best medical science in the world that proves that lockdowns have no effect, no significant effect, and in some cases, in fact, a detrimental effect on the transmission of COVID-19. So if they don't stop the spread, why would you ever use them? And we knew that before the pandemic started.
Okay, so we had another mistaken assumption that lockdowns have a favorable cost-benefit balance. What exactly do you mean by that, David?
All right, so I want to clarify right away that a cost-benefit analysis has nothing to do with money, because people always think it's about money. When you do the estimate of the situation, a cost-benefit analysis is used to determine each of the possible courses open to respond to an emergency. And what it does is it weighs all of the possible outcomes that are beneficial versus detrimental. We know and knew before this pandemic that the use of non-pharmaceutical interventions comes with severe costs, and I mean loss of life. the mental health, societal health, the impact on other severe illnesses and disease, the destruction of education of our children, the destruction of our economy, every one of those things has a massive negative outcome if you use non-pharmaceutical interventions or lockdowns. And yet, that whole cost benefit analysis process was completely omitted in the decision-making wave after wave after wave. And all you ever hear discussed every night on your television is the number of COVID deaths, as if people dying of cancer who miss diagnosis and treatment don't count. People who miss diabetes treatment, that we know the impact of 1 year loss of education on a student will have 3 to 5 years of death, reduced lifespan in their future.
All right, so just before break, we were talking about the cost benefit, and you were starting to talk about diabetes, cancers, and stuff. And one of the things we've talked about all the time, at least I talk about with my circle of friends, is the addictions, the suicides, the thoughts of suicides, the abuse. There's just so many things. You touched on some of them. We also haven't actually talked about some of the things that you just were alluding to there, like where you miss your cancer treatments or screenings and all heart, all these things. Go back to what you were saying just before break, and let's talk about those things.
So in the paper, we go through the cost benefit analysis process, and we cite case after case after case of the best studies in the world. And so I recommend people to go and review it. The fact is, things like mental health, the damage we've done to the mental health and the fear that we've created in people will cause damage for this whole next generation. We're talking decades. You never use fear as a tool. We said that at the start, but the mental health impact, the societal health impact, things like spousal abuse and child abuse are soaring. And we see newspaper articles about it, but people assume that it just had to be done to lock down and that these are just sad outcomes. You never had to lock down, and these cost benefit analysis outcomes were known before we used these non-pharmaceutical interventions. We should never have used them.
The last thing you talk about mistaken assumptions are lockdowns are the only effective option. So talk about that.
So let's go right back to the beginning again. Canada ranked worst in the Organization of Economic Developed Countries in protection of our seniors, because the very first thing you do in any emergency is look at who's most at risk. And we knew it was our seniors. 95% of deaths worldwide have been in people over the age of 60 with severe multiple comorbidities. In Canada, we ranked worst in protection of our seniors because we used that failed philosophy that locking down would protect them. If we use targeted protection on people with severe comorbidities and people over the age of 60, we could have dramatically, like other countries did, improved the outcomes for our seniors. So targeted protection, do not lock down, because then you remove all of the collateral damage out of the cost benefit analysis that shows all of the mental health, societal health, education impacts, other severe illnesses and disease, and the economic impacts. If you look at a country like Sweden, who did not follow this model, they now look like the champions worldwide.
So that leads into the last part of the paper, which was the priorities. Okay, so, and you just sort of touched on it, but so we must protect those most at risk by separating from the threat. So this whole issue of mitigation, you were talking about that a bit. Expand on that, because there's a couple of things you guys suggested.
Number one, if we had actually quarantined our seniors' homes in the first wave, and by the second wave, developed targeted methodologies to protect our seniors and those with severe comorbidities living outside, 77% of all the deaths in Canada occurred in our long-term care homes in the first two waves. Unconscionable. We abandoned our seniors. So what do I mean by quarantine? I mean staff and residents. The same stuff we were talking about, Dean, back in January,
Absolutely.
Which we still to this day haven't done, and the use of rapid testing in those same types of settings that was completely abandoned until December. I mean, there's just so many ways we could have targeted that protection, as well offering people real advice on how to have better outcomes if they do catch COVID. The whole development of treatment options that seems to have been neglected, but that we should have been focusing on.
Second thing you mentioned in terms of looking at better outcomes is critical infrastructure. Let's talk a bit about that.
So let's talk about the hospital system. Critical infrastructure is water supply, our power grid, all the other things that were completely ignored by our medical officers of health. And I understand why. It's not their area of expertise, but emergency managers always look at that first. Because if you can't get potable water, if you can't get electricity into your homes, you're going to have terrible, terrible outcomes. But let's talk about the medical system. We're now in the fourth wave here in Alberta, and we're actually being told that there are less ICU beds now than there were in the second wave. The entire concept of critical infrastructure, even if you only look at the medical system, we should have been increasing capacity because we know COVID is here to stay. It's endemic. And we know as a coronavirus, it's going to mutate. So we're constantly going to be seeing wave after wave for the future. Not till this year, for the future. So we should have been looking at our acute care bed capacity and our ICU capacity and making sure that we're ready for this forever.
Hold that thought. I want to come back after break to finish it up. Welcome back to the Hill Update. I'm talking with David Redman, and we're talking about what we could have done better or what we could do as we move forward. We're talking about critical infrastructure. David, one of the things I make a note of is that I don't know what the total bed count is now because I know it has changed. You mentioned about ICU beds, but I think it was around 200 on average that Alberta has, and correct me if I'm wrong. But I'm looking in the States, and we're not going to talk about healthcare, but this leads to your point about critical infrastructure. In places like Alabama, which is similar in population, has got 1,500 ICU beds. And so, we always talk about a great healthcare system we have, but sometimes we don't realize that we're really maybe not doing as well as we could be if we start looking at other places of like size. And you were talking about critical infrastructure and ICU before we left for the break. You want to just finish that thought off? I think it's pretty important.
I think the key point is we're 18 months into a pandemic. And if we haven't been developing our hospital system to be ready for coronavirus to be with us forever, then we need to replace the people that are in charge of our medical system. We should have been constantly reviewing and developing and watching what's happening to people that had the variants before us and seeing what was coming. It's almost like every wave is a surprise in Canada, and like we think coronavirus Canada is different than coronavirus world. And I just want to give you the one thought on that. In Israel, at this point in time, 90% of the people that are in hospitals are double and triple vaccinated. In Great Britain, in the UK, 50% of the people in hospital are double and triple vaccinated. Israel's 6 months ahead of us. UK is 3 months ahead of us. Guess what's going to happen by December in Canada?
I think we've got a pretty good idea.
Why should this be a surprise?
Yeah. No, absolutely. Now, the last thing you talked about in the suggestions for achieving better was the shift from focus from fear to confidence. So you've talked about that all along. We talked about that back in January. You said this focus on negativity and fear is debilitating. So talk to us about how we could do and how we shift from fear to confidence. I mean, it seems pretty overwhelming.
So we need to put coronavirus in perspective with other diseases in our country. Let's start right there. That's one of the simplest things to do. First of all, we should never be saying that our hospital system will be overwhelmed. We need to fix our hospital system so it's not going to be overwhelmed and tell people that it won't be. Then the second thing is, let's put the virus in context. If you're between the ages of 20 and 40, you are 5 times more likely to be a vehicle fatality than you are to die from COVID-19, even counting Delta. You are twice as likely, if you're under the age of 60, to be a vehicle fatality. We have blown COVID-19 into this earth-shattering, deadly disease, and it's simply not. If we had taken care of our seniors and had shown the public how we were taking care of our seniors, the number of deaths would have been halved. And then we could have shown that everybody else was not at risk by placing the disease in perspective. And we need to be doing that every night, every day, with all the evidence that's being produced.
Okay, we got about a minute and 15 left. Listen, I've always been opposed to lockdowns like you have been. I've been opposed to vaccine passports, which in my opinion is another form of a lockdown. Do you have any thoughts on vaccine passports?
Okay. International vaccine passports, I totally understand and agree with. I've carried my yellow international certification of vaccinations my whole life because any country can decide what they want to do. But domestically, it's illegal and unconscionable. We know that the coronavirus has already escaped our current vaccines. I just told you the numbers in Israel and the UK. It's already 25% of the people in hospital in Alberta are fully vaccinated. So to say to somebody that this is a disease of the unvaccinated is simply not true. And so why are they perpetuating it when they already know from other countries what the real facts are? Not to mention the fact that the denial of people access to their lives is going to have those massive collateral damages, which cause at least 10 times the number of deaths and more than that in damage. We have to stop the idea that people are guilty of coronavirus if they catch it, and that people who aren't vaccinated are the great evil of our country.
David, thank you so much. As always, I appreciate your insight, and I wish more people would be listening to the great advice that you're giving. Thank you very much for being here today.
Thanks for having me, Dee.
Thank you once again for joining me on the Hill Update this week. Once again, as we heard from David Redman today, data is important. We need to be looking at who and what this is affecting, and we need to respond accordingly. We have lots of data. Let's make sure we follow the data. Thanks for joining me this week.